Dear listeners, I'm Huan-Huan from the First Affiliated Hospital of Nanjing Medical University. The title of my study is Determining Disease Activity and Glucocorticoid Response in Thyroid-Associated Ophthalmopathy, Preliminary Study using Dynamic Contrast Enhanced MRI. Thyroid-associated ophthalmopathy, also we call it TAO, is a common inflammatory eye disease associated with thyroid dysfunction in adults. The natural course of this disease includes an initial active phase and a subsequent inactive phase. The former one features optic tissue inflammation, therefore it could be treated with systemic glucocorticoid therapy. However, the latter one is featured by optic tissue fibrosis, and a follow-up or symptomatic surgical treatment is usually suggested. Therefore, the first crucial task during the clinical evaluation of TAO is to accurately determine the disease activity. The clinical activity score is widely used to assess the disease activity previously. However, the subjectivity potentially limits its accuracy. Once active TAO is defined, the next important task is to precisely determine the treatment response to GCs, considering that about 20 to 40% of patients are unresponsive to GCs. However, efficient clinical approaches for assessing the responsiveness of GCs before treatment are still lacking. Optical MRI is increasingly used to evaluate TAO. Many studies have confirmed the role of multiparametric MRI of the extraocular muscles in determining the activity of TAO. Other researchers have also reported that MRI can detect the heterogeneity of EOMS and subsequently help in determining the treatment response to GCs. However, previous imaging-related studies have mainly focused on the pathological projection of optic tissue-associated inflammation and fibrosis, and further physiological alterations within EOMS are rarely mentioned. Dynamic contrast enhanced MRI can provide quantitative information about the microcirculatory fusion and permeability of various tissues. Previously, only one study used the DCE-MRI to evaluate perfusion changes in the EOMS of patients with TAO. However, they analyzed the DCE-MRI using a model-free approach. And the major limitation of the model-free calculation was that it was not necessarily relevant to the physical essence. In addition, the internal relationship between the perfusion features of EOMS and the treatment response to GCs has not been explored. Therefore, the purpose of this study was to assess the role of DCMR-derived model-free and model-based parameters in discriminating active from inactive TAO phases and responsive patients with TAO after GCs treatment from non-responsive. This is a flowchart of our patient enrollment. Between May 2022 and September 2023, 75 patients with TAO were recruited from the Department of Endocrinology at our hospital. The inclusion criteria was as follows. Finally, a total of 65 patients with 130 involved eyes were enrolled in this study. Disease activity was assessed using a modified 7-point CAS and recorded for each unit of eye. Also, the disease severity was assessed, and other clinical data were collected. Thereafter, 41 patients with TAO with 82 active eyes and 24 patients with TAO with 48 inactive eyes were included. Then, focusing on the 41 patients with active TAO, 27 among them received a standard intravenous GC administration. 22 of the 27 patients completed the GC treatment and the final determination of treatment response at the endpoint of the current collection. Each eye was grouped into either responsive or unresponsive according to the therapeutic outcome. Finally, 50 patients with TAO with 30 responsive eyes and 7 patients with 14 unresponsive eyes were included. All the MRI scans were performed on a 3 Tesla unit from Siemens. A chronal DCE-MRI was performed using a 3-dimensional vibe sequence. The DCE-MRI excision included 50 phases and a total time of about 5 minutes. All quantitative measurements were performed for each unit of eye. First, imaging data from DCE-MRI were imported into a dedicated post-processing software. DCE-MRI quantitative tracer kinetic modeling was based on a 2-compartment modified Toft model. The model-free parameters included TTP, AUC, and maximum ascending slope. And the model-based parameters included K-trans, KP, and VE. Then, polygonal ROIs were manually outlined on the EOMS to locate the maximum cross-section behind the eyeball, representing the site of the muscle bellies. Afterward, simplified histogram parameters of the ROI union were obtained. Here are the statistical analyses we used in this study. Now let's turn to the results. This table summarizes the patient's characteristics. We found that duration of TAO, CAS, FT4, VA, VFI, and proptosis differed significantly between the active and inactive TAO groups, while only the duration of TAO differed significantly between the responsive and unresponsive groups. Regarding the DCE-MRI derived parameters of UMS, we found that patients with active TAO had significantly higher TTPs, AUCs, higher K-trans 10s and K-trans mean, and higher VEs than inactive patients. Then regarding the treatment response, we found that responsive patients showed significantly lower TTP minimum, higher K-trans mean and K-trans max, and higher KPs than unresponsive patients. After the multivariate logistic regression analysis, we found that TTP mean and VE mean were independent predictors of the disease activity of TAO, whereas TTP minimum and K-trans mean were independent predictors for the treatment response to GCs. To determine the disease activity of TAO, RC analysis revealed that the integration of TTP mean and VE mean performed the best, with an AORC of 0.687, followed by VE mean alone, and then TTP mean alone. Then, to determine the treatment response to GCs, combining TTP minimum and K-trans mean showed good performance, with an AORC of 0.821, followed by TTP minimum alone and K-trans mean alone. Here are some representative cases. The left figure presents one active TAO and one inactive TAO. We can detect that the TTP mean and VE mean values on bilateral orbits for the active patient were significantly higher than those of the inactive patient. Then, the right figure presents one responsive TAO and one unresponsive TAO. The TTP minimum value on bilateral orbits for the responsive patient was significantly lower, while K-trans mean value significantly higher than that of the unresponsive patient. In conclusion, our preliminary study indicated that DCE-MRI-derived perfusion parameters could help determine the activity of TAO and the treatment response to GCs. Our study establishes an important foundation for the use of DCE-MRI to evaluate patients with TAO in clinical practice. Thank you for your attention.